So we'll move on to equilibrium and hearing, and there is a reason that we're connecting equilibrium to hearing. They're all part of the same system. We're going to call that cranial nerve 8 vestibulocochlear. There are two divisions of it, and we will discuss what those divisions are. However, that information tends to travel together. Now, anatomic regions of the ear, we are going to have an external ear, a middle ear, and an inner ear with very clinically distinct profiles, right? So let's say, for example, the difference between an external ear infection, middle ear infection, inner ear infection, those all have really different consequences because of their position anatomically. So the external ear is going to include the auricle of the ear, which has a helix and antihelix, tragus that we don't have an image for. Don't worry about the tragus on your list. Everybody freaks out about the tragus. Then you have the external acoustic meatus. This is where you're probably sticking your Q-tips. Technically, you're not supposed to because you risk injuring that tympanic membrane right there, that eardrum. But, you know, presumably this is the part that you can reach with a Q-tip. The dividing line between the external ear and the middle ear is going to be that tympanic membrane, so that is the boundary. You do have a membranous boundary between these two structures. Your middle ear contains the ossicles. So the ossicles are the smallest bones of your body. They're the ones that are going to vibrate to transmit sounds to your inner ear, but we're not done with middle ear anatomy yet, so I'll finish up here. The ossicles are the malleus, incus, and stapes in order, from the eardrum to what we call the oval window. And then you have this right here, the auditory tube, and I'm sorry, but there's 3 different names for it. The auditory tube is one, the eustachian tube is another, and the pharyngotympanic tube is also an option. This has a lot of clinical significance to you, so I do want you to learn all 3 in this case, because this goes to your nasopharynx. What that means is the throat. The pharynx is the throat. We're going to see the throat a few times. We're going to see the pharynx a few times. You have a nasopharynx, which is the throat behind your nasal cavity, an oropharynx, which is the throat behind your oral cavity, and a laryngopharynx, which is the pharynx behind your larynx. Nasopharynx for the auditory tube, yeah. The pharyngotympanic tube, the auditory tube, and the eustachian tube. E-U-S-T, however you spell crustacean at that point. Eustachian. Okay, there's clinical relevance here. The clinical relevance is if you've got a toddler with frequent throat infections, that means they're going to have frequent ear infections. If your kid has frequent ear infections, they're going to have frequent throat infections, right? Because in a child, this tube is, you see how it has this orientation where we've got drainage into the nasopharynx from the middle ear? In a child, it's more horizontally located. It hasn't grown into this orientation yet, and it's a lot shorter. So any bacteria in the nasopharynx, stuff that you could have snorted, inhaled, right? That can travel really easily to this middle ear, and that can interrupt the ossicles, which is going to interrupt your conductive hearing. That's why you're learning this. Now the inner ear, that's going to be the structures of the vestibule and the cochlea and the nerve itself, the vestibulocochlear nerve. So at this point, we're talking neural structures. So an infection here, that would be neural, right? This would impact, an infection here would impact ossicles. An infection here would impact probably the tympanic membrane and some skin. Not quite as big a deal, right, as an infection here. Or problems here are going to be really different from problems here. What else? This is distinct for the vestibule. These 3 little, I'm going to call them hula hoops. And then the cochlea is the snail shell shape. Okay, we did all of that. The external ear, again, within the external auditory meatus, we do have cerumen. We do have glands lining that epithelium that secretes cerumen, which is earwax. Middle ear, malleus, incus, and stapes. Here's the malleus, incus, and stapes. So what's happening is sound waves are going to come in. They're going to vibrate the tympanic membrane. That's going to in turn vibrate the malleus incus and then the stapes. And here's a webcomic. So that's from the Awkward Yeti. I've purchased his book for the sake of utilizing his comics educationally. I think they're really well done. Okay, inner ear. Again, you've got the vestibule, or sorry, the vestibular system. You've got the cochlear system. Your vestibule includes semicircular canals. Whee, they look like hula hoops. You've got 3 hula hoops. You got hula hoops oriented this way. You got hula hoops oriented this way, and you've got some oblique hula hoops too. And I'm not using hula hoops accidentally. Think of like the really fancy hula hoops that have the water in them, and maybe there's like some sparkles and they make some sound like whoosh, whoosh, whoosh. I want you to think of those when you think of these semicircular canals. So back to the anatomy really quick. The vestibular system has semicircular canals. There's going to be a vestibule, which is like the opening, the entrance. If anybody's into architecture, a vestibule is sort of a generalized term for the entryway, right? That vestibule includes the utricle, which is this bulbous thing over here, and the saccule, which is this bulbous thing over here. And each semicircular canal also has an ampulla, a little broad portion right at one part of the hula hoop where it connects to this vestibule over here. Now you're going to notice that there's sort of a bone color here, and then there's a sort of pink color here. That's going to differentiate the bony and the membranous labyrinth. Are you ready for the labyrinths? I didn't hear if that was a yes or a no, but I'm going to assume it was a no. Okay, but we're going to go ahead anyway. The bony labyrinth, that's this whole structure as a whole. It's actually sort of in negative space. It's protective. It's encasing all of these structures. Within the bony labyrinth, there's actually a membranous structure. Now, if you took this semicircular canal, this fancy hula hoop, and you took a little cross-section slice of it, you would have this appearance right here. And only this stuff in pink, that's the membranous labyrinth. That's the fluid we're really going to track and that we're going to really pay attention to. That's got endolymph in it. The bony labyrinth is the rest of it. And then you've got paralymph in between the bony and the membranous labyrinth. So that's going to be, that paralymph is going to be more protective. The endolymph is going to be more functional for what we're actually going to talk about for our sensations here. The cochlea, it's all continuous between the vestibule and the cochlea. This bony and membranous labyrinth, it's all connected. It's all the same fluid flowing between them. So now you take the snail shell shape and you do a little cross section of that. You cut it out and you get this right here. So you're going to have, again, the paralymph here and here, and then the endolymph right in this pinkish part right here. So we will ultimately be zooming way in on what's going on right there to cause sound perception. We're not there yet. Right now, we're just focusing on the difference between bony and membranous labyrinth. And the difference is form and function, right? So the sensory epithelium is always going to line the membranous labyrinth. So the pink is where your actual sensory epithelia are going to be. There's going to be a couple of different sensory epitheliums, though. It's not just one. Are we doing okay so far? Am I still coherent? Can't tell. Okay. Now again, the membranous labyrinth contains endolymph between bony and membranous labyrinth. That's where paralymph is, and that's going to support and protect. Job of paralymph is support and protect. We pretty much did that. We did utricle and saccule. This is if you just took the membranous labyrinth out of the bony labyrinth entirely. You would get these structures. Okay, let's talk about our first sensory epithelium. Inside of the vestibule, the utricle and saccule, you're going to have an epithelium known as the macula. There's a lot of vocab. I know there's a lot of vocab. I didn't decide this. So the epithelium is the macula, inside the ventricle of the saccule of the vestibule. We're coming back to this concept of hair cells. Back on familiar ground, hopefully. We've got hair cells again. In this case, we're going to call them kinocilia and stereocilia. And it's not that they're going to cause movement, it's that they are going to respond to movement. We'll see what that movement is in just a second. You're doing awesome with the way you're thinking of it, though. Good job. Okay, so we're in the macula. I want you to picture like a 1950s housewife with her Jell-O dessert in like a large tray. We've got our Jell-O dessert. We've got like a bunch of fruit suspended in the Jell-O dessert. And she's going to like lose her balance because she's on a lot of Valium probably. And this whole Jell-O dessert is like gonna tilt. And now, of course, we got to step away from the Jell-O dessert idea. Now there's like hair sticking up into the Jell-O dessert. Sorry, it's gotten gross. And when she tilts the pan, those hairs are going to bend. Yeah. 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 Did we get it? I saw some light bulbs. Or do you have a question? Did that make sense? Okay. So when we tilt our heads, when we change the position of our head, we've got a gelatinous layer. It's called the otolithic membrane. There's actual gelatin in there, not like Jell-O gelatin, but the sort of collagenous stuff that is the same stuff we make Jell-O out of. That's in a layer over these hair cells. And you do have these otoliths, these microscopic little calcifications that are like the fruit in the Jell-O, right? They kind of help weigh it down so that it's gonna shift a lot more. So when that Jell-O shifts, it's going to bend the stereocilia and the kinocilia, and that physical bending, it's a physical deformation, is going to cause action potentials to fire along that sensory receptor. And that's going to give you head position. Even if your eyes are closed and you have no other information, even if your proprioceptors broke down in all of your muscles and the joints of your neck, you would still have that information coming from the otolithic membrane and the macula. Yes, it does. It has a lot to do with equilibrium. So one thing you may have noticed there is that I mentioned you've got visual information telling you where your head position is at, you've got proprioception telling you what your head position is at, and you've got the Jell-O layer telling you what your head position is, right? It's possible to have a mismatch between those three things, right? You could be inside of a plane and you're tilted up, but your eyes see you as stable. And so now you've got a visual mismatch between your eyes and your proprioceptors and your vestibule. That is where motion sickness comes from. That's what we're getting at. This fluid, this endolymph that travels through that membranous labyrinth, it also plays a role in things like certain vertigo disorders like Meniere's disease. So vertigo is another thing here. Let's see, stereocilia, kinocilia, hair cells, macula. On your worksheet today, I think I have a question where I ask you where the sensory receptors are located, and some people will put macula and some will put otolithic membrane. I'll take either one. Those are both acceptable for that. I'll probably annotate the opposite one compared to the one you write down. You could just say otolithic membrane and macula if you want to be complete, but it's up to you. Okay, so there's what that Jell-O layer looks like. And there it is bending those hair cells down. So you know which way your head's tilted. But that's actually not those semicircular canals. That's actually just out here in the vestibule. So you're actually going to have a slightly different function for these cool hula hoops. We're going to have a similar situation going on with the hula hoops. With our semicircular canals at each ampulla, that thickened portion that it connects it to the vestibule, we're going to have this structure right here. It's like a modified jello dessert. Instead of having that jello dessert out on a big tray, now you've got like a sculptural jello dessert going up like this. But you still have hair cells sticking up into, sticking stereocilia and kinocilia up into this sort of jello-y structure. So the jello-y structure is called the cupula, crista ampullaris. Yeah, this whole thing is the crista ampullaris. The gelatinous thing is the cupula. And of course you have hair cells right here. So what's happening with your shiny fancy hula hoop is, let's say I start spinning in my chair, which I'm definitely not going to do today, but normally I would. So let's say I'm spinning in my chair. That fluid in my super cool hula hoop is gonna go around in this specific hula hoop because that's one that's oriented in the same direction that I'm spinning. And that fluid is going to rinse over that cupula and bend it. So it looks like that. And the bending again of the stereocilia and kinocilia and those hair cells sends a nerve impulse to our brain that tells us that we're spinning in a circle. And then of course we have one that's going to tell us if we're spinning end over end, if we're like doing a somersault or something like that, or we're in a horrible car accident and our car's going end over end. And we also have a sort of oblique angled one to tell us about that too. So if you were in a gyroscope, like kind of going around, all of these would be sending fluid through the semicircular canals, bending that cupula, sending signals about rotational momentum. Good? Oof. All right, and then that's going to travel through that vestibular portion of vestibulocochlear. What brainstem level for cranial nerve 8? Medulla oblongata. So technically at the border between pons and medulla, but I like medulla oblongata. I'm a fan. And then all of that balance information, equilibrium, head position, rotational movement, that gets sent to all of the places that need it, like your spinal cord, like your brainstem, like your cerebellum, like all of those motor areas that we talked about so much. Cool, right? Big fan of the vestibular system? Important stuff. Okay. And now we can wrap it up with hearing. Last one. Last but definitely not least. Let's talk about that cochlea. This is a very visually confusing picture the first time you see it. So here's what's visually happening. We've taken one long tube and we've circled it around like a snail's shell. And what they did for this image is they took a little pie slice out of it, three-dimensionally. We've actually already seen this as one. If we took just one cross-section of the tube, it would look like just one piece of this. This is just like the branching pattern of that snail shell. This one's continuous with this, and then we took a pie slice. This one's continuous with this, and then we took a section there, got pie slice. Does that make sense? How it makes sense? So now we zoom in on just one cross section and we isolate that. And that gives us again our bony labyrinth versus our membranous labyrinth, our paralymph versus our endolymph. And then we're going to have a specific name for the chamber for paralymph that is located superior and the chamber for paralymph that is located inferior. This is going to be scala vestibuli. And this is going to be scala tympani. We're going to have a specific way that sound waves are going to travel through these. And we're going to use those vocab words for that. And then we need to pay special attention to the membranous labyrinth here. So now we're going to focus way in, not just on the membranous labyrinth, but just this epithelium right here, because we need to find the hair cells. And here's where the hair cells are. So again, those hair cells are yet again in the membranous labyrinth. So what we're going to have here in the auditory portion, it's not going to be a jello layer anymore. We're going to move on from that. We're going to have a tectorial membrane. Not to be confused with a tympanic membrane. Where was the tympanic membrane? That's your eardrum. You can poke it with a Q-tip. Please don't. But you can. Tectorial membrane, you cannot poke with a Q-tip. You shouldn't. You can't. If you can, something is seriously wrong, right? Tectorial membrane is within the membranous labyrinth within the cochlea. So what's going to happen is sound waves are coming in. They come in through the cochlea. We'll see how they get there. And ultimately, they're going to compress the tectorial membrane in different places depending on pitch. And when that tectorial membrane compresses, it's going to deform your hair cells. That's what we're getting at this whole time, right? Mm-hmm. They've lost hair cells, yes. Losing sound, losing hearing for different pitches is based on the hair cells and their position too, which is actually what we're getting up to next. So again, we can go see the histology, the tectorial membrane, and the hair cells that will be direct. There's the cilia directly in contact with that tectorial membrane, like a piano. You press a key, you get a tone, right? Now what we're going to do to understand pitch is we're going to take the snail shell and we're going to just hypothetically unroll it. Real life, you cannot unroll it. It's embedded in bone. It doesn't happen that way. But to visualize pitch, we're going to imagine unrolling it. That's what's going on here. And what that gives you is that scala vestibuli and scala tympani are actually continuous. So here's how it looks, all straightened out. And here's another part where I get really loud. So I apologize to the dental patients who are right on the other side of the wall for what I'm about to do. Okay, you have sound waves come in. They vibrate the tympanic membrane, the malleus, incus, and stapes. The stapes stomps on the oval window. And that sounds those sound waves in to the scala vestibuli. And depending on the pitch, they may exit scala tympani and out through the round window. That's the other anatomical thing here, is the round window. Here's what this sounds like. Higher pitches are going to be very proximal to the oval window, and as pitch gets lower, we get further away from the oval window. So it goes like that, which I will not repeat. And you know, lower pitches, I haven't been high for that, but whatever. I'm not that kind of high. High pitched. Too high pitched for that. Okay. Any questions? Cool, right? Okay, so that's why people tend to lose higher pitches earlier in life than lower pitches. Higher pitches are right there next to the oval window with that stapes stomping on it, right? So we do tend to lose higher pitch sounds sooner in life.
Do dogs have that? Is that different in dogs, so they can hear really high pitches?
Oh yeah. So this epithelium absolutely will determine the range of sounds that you can hear and your sensitivity. So yes, this will be a slightly different arrangement for dogs and cats. Yeah. A friend of mine from grad school actually did his capstone project on the vestibular structure of sloths. So humans were bipeds, we're up like this, but a sloth, like their normal position is like this. So we studied how different that would be for rotational head movement. Yeah, he did like a 3D print of the vestibular system of a sloth. It was so cool, so cool. So jealous. So yeah, there is variability between animals. And yeah. Let's see. I don't care about that. I care about tectorial membrane. There we go. Now again, it's the vestibulocochlear nerve. So you have a branch coming from the vestibule, you have a branch coming from the cochlea. They join up. They actually go to slightly different nuclei, but both within the medulla oblongata. And then they go, honestly, the auditory pathway is really, really complicated, so I'm not going to have you learn every part of the auditory pathway. I think it's not going to help you that much right now. I'll point out it's gonna hang out briefly at the inferior colliculi. What does the inferior colliculus do? It's the bus one. What part of the bus one? You hear a sound, so you look towards it. So obviously we've got to have a synapse in that place so that we can hear the bus, look towards it, and we can have our auditory reflexes. Cool, right? Let's see. I promised that visual was lateral geniculate nucleus. Auditory is medial geniculate nucleus of the thalamus. It's just a synapse place. And then it goes to the auditory cortex. Where's the primary auditory cortex? Temporal lobe. Yep. So again, I don't want you to overthink this one. Cochlear implants is our last topic. Any questions about the physiology of hearing? It's a lot. I know it's a lot. Okay, let's talk about cochlear implants. Does anybody here have experience with the deaf community? Do you want to get on a soapbox? Mm-hmm. Mm-hmm.
My best friend has bilateral cochlear implants, and so does his brother,
Mm-hmm.
which they don't know how, that somewhere in their genetic tree somewhere, but they
Yeah.
don't know anyone.
Interesting. Okay. So I'll put a couple of things on the recording and then I'll stop it to go on my rants. So the things I want to put on the recording is a cochlear implant is not natural hearing. A person with a cochlear implant is not going to hear the way my voice sounds right now. It's not going to hear music normally. In order to put a cochlear implant in place, we have to strip away any remaining hair cells, which is significant because most people who are legally deaf are not profoundly deaf. Most people have some residual hearing. So if somebody had residual hearing before, stripping that all away to give them a cochlear implant is actually going to be very life-altering for them. Like before, maybe they could tell that a bus was honking, but maybe not necessarily know it was a honking bus. That's a very big difference to not being able to tell that a bus is honking at you at all. In order for, if somebody is born deaf, in order to become fluent in speech, we have what we call a critical period of language acquisition. So a baby who is born deaf would need a cochlear implant close to time of birth in order to develop fluent speech. So it's not really possible to let kids grow up and decide for themselves if they want a cochlear implant. And all of this has really, really major implications because there is this thing called the capital D deaf community. They consider themselves almost like an ethnicity, a culture. It's a distinct language. It's not English in hand form. Semantically, it's closer to French because it was invented by a French guy. So it's a distinct culture. It's a distinct tradition. Hearing parent or deaf parents, capital D deaf parents, would be ecstatic to have a capital D deaf child. And they may not necessarily want to be treated as people with disabilities, and that's something you should all know as nurses. If a baby is born deaf, what's supposed to happen is that an audiologist comes along to talk about cochlear implants, and somebody from the deaf community comes along to talk about all the opportunities this child now has to become part of the deaf community. That's supposed to happen. Does it always happen? Probably not. So I want all of you as nurses to be aware of that issue with cochlear implants and the way that it's playing out in society.